Good evening, ladies and gentlemen. I'm delighted that you chose to come to the Liverpool Medical Institute tonight rather than watch the Liverpool football match. I mean, there's really no point watching Liverpool football matches anymore because the results and inevitability. The other attraction tonight was an inaugural lecture by one of our colleagues in the university, and that may explain why some of our usual academics have gone there instead. I think that's a bad choice. This is clearly where you should be tonight. John Edmunds is Professor of Infectious Diseases Modelling at the London School of Hygiene and Tropical Medicine. He's a graduate of Imperial College London in 1994, and his projects include the flu survey, which is where I first sort of started to take notice of him. And that's the UK's biggest crowdsourced study of influenza, and I religiously type in my symptoms still. He pivoted that to work for COVID-19. He's also worked on the analysis of human papillomavirus vaccination policy in the UK, and in 2009, swine flu pandemic. Now, I didn't know that at the time that I had rolled up my sleeves and was working in the hot zone in Sierra Leone, John was hard at work working on Ebola epidemiology just down the road, probably in the British consulate, which had a very nice tennis court, swimming pool, and Chris Whitty was in there. He never came out of there either. But John did actually do some pretty good work on Ebola epidemiology, raising the concern globally about how bad it was getting in 2014. He also did I think he did the stats behind the VZV EBOV trial as well, which is a very successful vaccine study. And for that he got he was appointed officer of the Excellent Order of the British Empire in 2016 for his services to infectious disease control. Subsequently, he's been sitting on several national and international committees, including SAGE, which is the Scientific Advisory Group for Emergencies, where he gave advice on COVID. He's been a leading figure in SPI-M, which is the Pandemic Modelling Committee, subgroups for JCVI, and also on the international stage, the WHO Polio Research Committee and CEPI's Scientific Advisory Committee. And all for all of this, he was recognised by his peers by election as Fellow to the Academy of Medical Sciences in 2018. And most recently, and quite rightly, he was knighted in the 2024 New Year Honours for his services to health and medicine. Please would you welcome him to the stage to give his presidential lecture on my behalf. Thank
you. Thanks very much. It is a real honour to be here. So thanks very much, Callum, and thanks for having me. What do I do? Just click that, is it? Yeah. Okay. So I'm going to tell you something about the role of mathematical modelling in pandemic decision making. I was going to maybe bring in some other things, other epidemics, including Ebola, but in the end I thought that's just so much to do just related to COVID that I think I've decided just to stick to COVID. Okay. I'm going to try. I've got about 40 slides. I'm going to try and finish by 8 o'clock. They're in bulk. They're in groups, so I can drop some if I'm going too slowly. But this is.
Enjoy yourself. Knock yourself out. We're enjoying it.
Okay. So. Do feel free to interrupt, just as Callum just did. Okay, so because it does actually make it a lot more interesting for me. So I'm happy to take questions and interruptions as we go along. So I'm really very happy to do that. So I'm going to tell you something about mathematical models of infectious diseases. I'll illustrate some of their uses. I mean, there is an enormous amount of work that was done in COVID, just by my group. So it's very difficult to sort of pick just a few bits. So, but I'm hoping to give you a little bit of an illustration of how they're used to help inform decisions. And I'll say something about lessons that I've learned. I don't know whether they're general lessons learned, but some of the lessons that I've learned through this process of using models, particularly during the COVID pandemic. Before I go any further, these are all the people who did all the work that I'm going to show you. So there's a huge group of us. So this is the group that were working on COVID modelling at the London School. I'm not going to name them because if I start, then I'll spend the next half an hour thanking them all. But they were amazing. Okay, so we'll start with a definition. So what is a mathematical model? So if you look in the Oxford Concise Dictionary, you'll see this definition: a simplified, often mathematical description of a system, in our case, an epidemic, to assist calculations and predictions. And I think that's pretty much sums up what it's all about. So it's a simplification of if you think about the spread of infectious diseases through our communities are incredibly complex systems, the most complex things really on this planet. And how does the disease spread, this infection spread through those sorts of communities, jump between communities and so on? It's incredibly complicated sort of thing. It involves interaction with this virus, with our immune systems, as well as our own interactions with each other and so on. And so that is a very complex system, and what a mathematical model tries to do is boil it down to some very simple, distill it down to some very simple things that are then can be used for predictions or just understanding the system. So that's what it is. I'll give you, at the bottom of this slide, I've also got a distinction. I'm going to make a distinction between statistical models and mathematical models. So statistical models, sometimes they're called phenomenological models, and they describe the empirical relationships between phenomena. So, and they do that in a way that is consistent with any fundamental theory, if there happens to be some, but not dependent on that fundamental theory. A mechanistic or mathematical model is based on the fundamental laws that are present in natural sciences, and the assumptions and the model itself, the relationship between variables, is built on assumptions which are entrenched in these fundamental laws. That sounds all a bit philosophical and difficult to follow, so I'll try and illustrate it with an example of firing an artillery shell, inspired by what's going on in Ukraine at the moment. So we happen to have a mechanistic model, thanks to Newton's work in the 17th century, of so we can predict very accurately. A gunner can predict, or actually a computer that he's using can predict very accurately where a shell will land, based on the angle, and I've got it up here. I don't know which one to press, but it doesn't matter. But just the top one there. Just one here. Okay, cool. So based on the angle and the angle, the velocity, and so on, then the gunner can predict where that, because we have an equation, we have a mechanistic explanation of a parabola, essentially, of the forces involved with the propulsion and the mass of the projectile and so on. So we can predict very accurately where that artillery shell will land. So we have a mechanistic understanding of it. Yeah? If we didn't have that mechanistic understanding, we'd be left with looking at an empirical approach. So we'd essentially fire off a shell, see where it lands, fire off another one, see where that lands, fire off another one, see where that lands, and the gunner would just go, well, I need to raise it a bit or lower it a bit or whatever. But if you do that enough times, you could end up describing, you could use an empirical model, a statistical model, which would say, well, okay, if the muzzle velocity is x and the height of the angle is y, then this is where we'd expect that shell to land. Yeah, so you'd have to fire that shell hundreds and hundreds and hundreds of times to build up a data set in order to be able to explain where shells might land using a regression model, the sort of stuff that we use all the time in social sciences and in medicine, these regression type analyses. And that's where we are, effectively, in most of medicine, and almost all of social sciences and medicine. We're left with the firing the shell lots of times and then analysing the resulting data, because we don't have an understanding. We don't have the equivalent of Newton's laws of motion. We don't have that fundamental understanding of what actually is causing. Why do people who smoke end up with lung cancer 30 years later? We don't actually have that fundamental understanding. We're getting grasps, bits of it, but we don't have that fundamental model of why smoking leads to cancer in some people and doesn't in others. And so we're left with this empirical approach, okay? So most of what we do in science, most of what we do, or certainly in biological science, medical science, and social science, is to fire lots of shells, look where they land, and then try and come up with an empirical model, a statistical model of that. Yeah? So trying to infer what's going on by looking at the data. But in biological sciences, there's about, I think there's one or two fundamental laws that do actually stand the test of time. One is, of course, evolution by natural selection, Darwin's theory. Another one is the germ theory. So you can't get measles unless you come into contact with somebody with measles, and you have to have not had measles before. So there's additional bits of information. But that fundamental, that germ theory, is what allows us to develop mechanistic, mathematical models of the spread of infectious disease. And I'll show you an example a bit later. But I've probably spent way too long on that explanation now, but just so you know, we are very lucky in that having this sort of germ theory allows us to be much more, allows us, with a mathematical model, usually allows us, if that mathematical model holds, that allows us to be much more efficient in our calculations and our predictions, and that's the situation we happen to be in with infectious diseases, and we're not with virtually all other areas of medicine and epidemiology. And the models that we can develop, they have a range of different complexity, from the very simple. This is a model. Yeah, it's a model of a train. Yeah, it's a model. It just happens to be a physical model, and it can be very simple or it can be very complicated. And the complexity depends on the question that you're being asked, how much money you've got, frankly, how much time and effort you're going to put into developing that model. Okay. And actually, one of the critical things is that you want a certain level of complexity, enough to be able to answer the question. You don't want something that's overcomplicated; it'll take too long, and an overcomplicated model requires more data in order to parameterize it. So you want a kind of Goldilocks type model usually. Now, the final thing on this sort of introductory slides is the main uses, and I'm going to illustrate some of these in the talk in the next half an hour or so. So one of the main uses of mathematical models is for understanding. So the very process of distilling something down to try and write a mathematical model helps your understanding of what the key processes really are. The second thing is when you do that and you try and parameterize, which try and put a parameter estimate, a quantitative estimate for certain things, that process also highlights, oh damn, we haven't got a quantitative estimate for that. We'll have to do something about it. We'll have to maybe do an experiment to fill that gap and so on. So that process helps our understanding by putting something down. Also, just writing something down in often a mathematical way, but just writing it down helps other people understand what you've actually done and what your thinking actually is, yeah? As opposed to just keeping it in your head. And I'll come back to that a bit later. Then, of course, this is what most people think they're used for, sort of projections and scenarios and forecasts. And I make a distinction between these two things, really important. So projections and scenarios are things like, what might happen if? So what might happen if we introduce vaccination against this disease or whatever, or if we vaccinate this group as opposed to that group? Those are projections and scenarios, okay? They're not forecasts. It's not saying this will happen. Forecast is what is that. It's this will happen. And I'll make one other sort of analogy just to make that clear. So we're used to using weather forecasts. So we get a weather forecast every day. It says it's going to rain in Liverpool again. And that's a sort of, what that is a probabilistic statement of what the weather might be like in Liverpool tomorrow or whatever. So it might say something like there's a 50% chance of rain. It's a probabilistic statement about, and it'll either rain or not, yeah? And so reality will come and it will either rain or not. There's a 50% chance. Okay, that's a weather forecast. A scenario is usually much longer term, done over a longer term, and you have some control over the future with a scenario. So they rely. So there are models that are used to look at what might happen to the climate as a whole over the global climate over the next 20, 30, 40 years, whatever it might be. Yeah? And what they suggest is that we could take certain courses of action that might change the future. Yeah? So they might change what might happen to climate change over the next. So if we reduce our carbon output, then perhaps we might avert some changes in the climate, in the long-term climate. That is a scenario. Yeah? That's saying, it's not saying this will happen. This is just saying these are the sorts of things that might happen if we allow it to go as it's going, and these are the sorts of things that might happen if we make some changes now. So it is possible to change the future, but you can't change the future in the short term, but you can change the future in the long term. And that's what these. So in a public health sense, the forecasts are only really looking at sort of hospital beds in the next week or two. And that's a probabilistic statement about how many hospital beds you'll need in the next week or two. You can't change it. It's a bit like your weather forecast. You can't change the weather tomorrow. It's either going to rain or it isn't. But the scenarios, the longer term ones, allow decision makers to make some choices and say, well, okay, if we invest in this or if we do that, then we might be able to change the future. In our case, change the future course of this epidemic. Yeah. Okay? So actually, although people kind of call these things projections, most of the time what we're dealing with are scenarios. And actually those are the things that are most useful. Okay, so that's long-winded explanation to what we're doing. And here's a simple, this is, as I said, this is a simple introduction, a simple mathematical model, this is the only one I'm going to show you with any equations, of an infectious disease. So what we do, based on the germ theory, remember I said that you can't get measles unless you come across someone, you actually come into physical contact with someone with measles. And so we can summarise that, we can split the population into three, in this instance, like in the very simplest case, three mutually exclusive groups. You're either susceptible to, let's say this is measles, you're either susceptible to measles, you're infectious with measles, the middle group, or you've recovered and you're now immune to measles. Okay? And the rate at which, we can describe the rate at which those groups change by these equations. And I'm not going to go through the equations, I'm just going to highlight this one bit, which is the really critical bit, which in this model says that the rate of change of susceptibles with respect to time, if you remember your maths, is equal to minus times beta times s times I. So it depends on the rate, on the number of susceptibles that there are in the population at a given point in time. Most importantly, it also depends on the number of infectious individuals in the population at that point in time. So the more infectious individuals there are in the population, then if you're susceptible to measles, then the higher your risk of becoming infected. If there's more people around, so at the height of an epidemic, for instance, there's more infectious people around, so if you're susceptible, your risk is greater. Whereas if there's no infectious people around, then your risk is none, even though you're susceptible. And this very simple thing, just this very simple term, just says that essentially makes an assumption that the rate at which these the susceptibles become infected is just depending on the way that we bump into each other, the way we come into contact with each other. And that simple term assumes that we all just mix in like a homogeneous. In a homogeneous mass, we just bump into each other. There's no structure in our populations whatsoever, and that's clearly rubbish. Which is why I've kind of highlighted it with the very simple end of the train model. Yeah. So this is the simplest transmission dynamic model. So we might want to build in a little bit more realism into our model, and so the next step up would be to assume that the population are structured in some way by some perhaps geographical way, so you're interested in perhaps spread between Liverpool and Manchester and London and so on, or it could be spread across age groups, or it could be spread across whatever it might be. And typically we would almost always in these sorts of models include age, because we know that people of different ages mix in a different way with each other. So and we actually have data on the way that they do that. So that's what shown. So this is the next most complicated model going up, and all we do is we just split these populations into different groups. So we might have 80 different age groups representing different ages, and then an SIR model representing the spread of, say, measles again, or whatever it might be across those age groups, within and between those age groups. And then we need some data on how people contact each other within age groups and between age groups. And these are data that we collected some years ago now, about 15 years ago, looking at contacts across different age groups. So this was done by a survey of asking people who they came into contact with, had a conversation with, and these are age of the participants in the survey, and these are the age of the people that they came into contact with. And you can see this very strong, this is a heat map, so where this is white, that's the most amount of mixing. And what you can see there is essentially children and young adults make the highest rates of contact, and they tend to make those with other children and young adults. Yeah, it's schools and universities. Okay, and then you also have this off diagonal here. This is mixing within the home, so this is children mixing with their parents. And you can see with adults here, this is working age adults mixing primarily with working age adults, and then the elderly make fewer contacts and so on. So you can see that there's this structure. So we can measure this sort of stuff, and we can put it into our mathematical models to better parameterize them. So that's what we do. Then you can add further complexity. So this is now looking at our model of COVID. So you can add in, for instance, an infectious class, and you can add in an asymptomatic or subclinical infectious, which may be less likely to be infectious, and so on. Okay, so that's the background. Let's go and use some of these models to help decision making in the UK. First of all, I'm just going to highlight how this information was used. So there were multiple groups that were feeding into central government and decision making in central government. The most important were these two. So there were SAGE, the Strategic Advisory, what is it? Scientific Advisory Group in Emergencies or something. Yeah. Forgotten. Anyway, Callum was on it. I was on it as well. So this is the sort of collated information from a huge number of other subgroups. I'm not going to go through them all, but a large number of other subgroups that were feeding into SAGE, and then the information was then collated, summarised, and then passed up to central government through the Chief Medical Officer, Chris Whitty, and the Chief Scientist at the time, which was Patrick Vallance. JCVI, which is the vaccine subgroup, was completely separate, and they also passed information up to decision makers like this. And these were getting input from many other organisations like Public Health England or UKHSA, it's now called ONS, and so on, and they were feeding into these decisions, these scientific advisory groups. The important one I want to mention is this one, which Callum just mentioned in the introduction. That's the modelling subgroup of SAGE, SPI-M. And the important thing to know about this is that there were a large number of different modelling groups, all of which were tasked with doing the same thing. So we were repeating, so at the same time, each of our groups were working on the same problem as the others. So we were given routine tasks that we did, like estimation of the reproduction number every week and short-term forecast that we were doing every week, but we were also given a task every week. So can we have some modelling input on task X? And it wasn't one group that did it, it was multiple groups. And I really emphasise that. So we were all, in some sense it's a bit of a waste because we were all working on the same problem. But the really critical thing was, by doing that, then it allowed an independent view from 3 or 4 different modelling groups. We weren't told how to do it, so we were allowed to take whatever approach we wanted, and then we presented the results back to SPI-M, usually a few days later, and then discussed it, and it went up to SAGE. Yeah.
Did you have the same data sets?
Mostly, but we didn't have to. But you didn't. Yes, we had the common access to the data sets. So SPI-M had access to actually fantastic access to data. But you could choose different. You may not use the same data. So some people might have been looking at, for instance, the death data, and other people might have been looking at the cases data or whatever. So you could choose whatever data you liked and analysed it in whichever way you liked. That wasn't ever specified. But what we were trying to do was all have input on the same question. So we were looking at same question from different angles, essentially. Okay, so I'm going to give you a quick whiz through some of the stuff we did right at the beginning and to highlight some. So this is now using some models in practice. I'm going to highlight a few things. So some of these are the kind of key questions that you get at the beginning of an epidemic. Part of it is just characterising. This is a new disease. We've never seen it before, so just characterising it in terms of its epidemiology, its case fatality ratio, fraction of cases that might die, reproduction number, and so on. But also characterising the delays between onset and illness, onset and hospitalisation, onset and death. I'll show you some. That's very important because the data are there delayed accordingly. Planning for how bad might this get, and then looking at the impact of some interventions. So I'll whiz through that. This slide just shows you some of the early, right at the beginning. This is the first sort of 5-6 weeks of the epidemic, and above the line I've just highlighted some of the key events. So this is when it was first notified to WHO on the 31st of December of 2019, hence it's COVID-19 just. First death was reported on the 11th of January. The first case outside China on the 13th. It was in Thailand and so on. So just first US case you can see on the 21st of January and so on. So this is the first case in Europe, which was in France, 24th, and so on. You can see these are the sort of events as they go. Along the bottom, these are the first papers just done from the group from SPY and the different UK modelling groups. So Imperial are always first. Imperial had their first paper came out on, first report came out on the 17th of January on trying to estimate the size of the epidemic in Wuhan. So at that point, 41 cases have been reported in Wuhan. The number of cases being reported in Wuhan on the 1st of January was 41. On the 18th of January, it was, anybody know? It was still 41. They reported exactly 41 cases. It looked like there was no epidemic occurring, but we were seeing cases outside China, so it seemed the Chinese data looked questionable, to say the least. I'll answer further questions on that if you so wish. And then Imperial revised that estimate. I'll show you I'll come back to this now. Imperial revised their estimate. This is on the 22nd of January. And then Lancaster with John Reed came up with a really nice estimate and an estimate of the reproduction number in Wuhan in China, and also an estimate of the size of the epidemic by the 24th of January. When our first estimates came out was towards the end of January, and these were various pieces of work that we'd done by the end of January, beginning of February. And I'm just going to highlight these two. I'm going to whiz through those two. One just on what was the size of the epidemic, so our estimate, which was a bit slower than Imperial's, a bit more elegant. So I'll show you how we did that in a minute. And then also I'll go through very quickly on some early results about feasibility of controlling this by contact tracing and isolation that we had done by the 7th of February. So it's absolutely phenomenal. This is just the UK. There were various other analysts and modellers working around the world. It's phenomenal what we knew about this disease in weeks. It's absolutely phenomenal. So the speed at which we got to grips with this was amazing. So by mid-February, we really did know a lot about this, and I'm still shocked that the government didn't really take any action until mid-March. So we did have a lost month.
Going to interrupt you.
Yeah.
When we cross your heart and hope to die for tell life, when did you first ever see the slide that this was a pandemic?
Early January. I wanted to cross off that it wasn't, because the data said it was only 41 cases, and that didn't change until I think about the 20th of January.
ProMed talked about a case in Thailand and Hong Kong that run about.
Yeah, the first case in Thailand was the 13th. That was when it was notified. Yeah, there were I didn't include the Hong Kong one. I put the first one in Europe, the first death. So certainly by mid-January. I mean, we had.
Say there were you.
We had 60 people working on it
Yeah.
by sort of the 20th, by the end of January, the third week in January, we had 60 people. They dropped everything, and they just worked on this and nothing else. Yeah, and we were not alone. Everybody else was doing the same. So yeah, it's a bit hard to believe that they didn't take that seriously, because we did. Okay. So I'm gonna highlight this one just to show you, and what I want to show. The reason why I've picked this one, it's really quite elegant. Two, it's just to show you how models are used, how they use data. Okay, so this is an example of how data is used and how data can be sometimes confusing, and how by bringing it all together, you can get a better understanding of what's really going on. Okay. So this is Adam Kicharski's work, which was first version of that was on our website on the 28th of January. And what he was trying to do was trying to work out how big the epidemic was in Wuhan at the time, and what the impact of any control policies were. Because on the 23rd they introduced a lockdown in Wuhan. Did it have any effect? You know, I've hinted that we were struggling with the Chinese data. So they might say that it's having an effect, but did it? Did it really have an effect? Can we estimate how big an effect it was? Okay, and what we were doing was not just using the data from China. So this is Adam's model. So again, you can see this susceptible is an exposed group here. This is those who've been exposed but not yet infectious. It's about a week between you being infected and you becoming infectious to others. So then there's the infectious class, and then there's the removed class. So it's just a very similar model to I showed you before, yeah. But in the red are the kind of clinical symptoms, and then they might be then come out as data. So you might be able to measure some of these things as in the data, okay. And that's going on in Wuhan, and this is going on in travellers that come out of Wuhan. So people were coming out of Wuhan. There was two groups of travellers coming out of Wuhan, just normal travellers coming out of Wuhan, catching the plane and going to Thailand or Japan or wherever it might be. But also, towards the end of January, beginning of February, we organised evacuation flights. So Western countries got their nationals out of Wuhan. Yeah? So they hired jumbo jets, put people on them, get to the airport, and we'll take you out. Okay. And initially, we didn't test ours. Actually, they were kept in somewhere in the Wirral, and they weren't initially tested. But other countries did, and we at SAGE said we should test those evacuees. Yeah, so they were tested with a PCR test. Okay, so we knew the prevalence in evacuees. Okay. And this is then this is now putting lots of different data sources together to try and get a better overall picture. Can we of what's going on? Okay. The top is an estimate of the reproduction number and how that was changing over time. That's sort of a result rather than a. This is the actual. These are some of the data. So these are you probably can't read this, but this is new cases in Wuhan. This is new cases in travellers coming out of Wuhan. The red is when they put the restrictions in place in Wuhan, the 23rd of January. So these are travellers coming out. You can see the prevalence going up. So the number of cases was going up in just people coming out of Wuhan. These are people getting picked up in Hong Kong, Thailand. These are not getting picked up. These are not cases getting picked up in Wuhan. They're getting picked up they're international travellers. And we're just picking up more and more cases. And if we're picking up more and more cases in international travellers, then the epidemic is going up. Yeah? And if you know the chance of you getting on a plane and going somewhere else, then you can work out the size of the epidemic. Okay? This is the prevalence in those people who were evacuated. So the evacuees, and they're tested with PCR, and you can see that's also going up. And by putting all of these together, then you can actually estimate the size of the epidemic in Wuhan. So if you know the prevalence and you make an assumption that the prevalence in those people getting evacuated is roughly the same as the prevalence in the population as a whole, then you can estimate the prevalence in the population as a whole, and you can estimate the size of the epidemic, and you can estimate the underreporting. So this is the estimate of the numbers of cases, and this is the reported cases. You can get an estimate of the underreporting of the cases, and so on. So there was massive underreporting. This is also an estimate of these weren't fitted. These lower ones, the data. The model wasn't fitted to this. It was then checked. This is like a validation. This is how many cases we would have expected to see in different countries exported through the travellers, and this is how many cases we did see. And there's a sort of relationship which suggests that many countries were picking up most of the exported cases at that time, and I strongly stress at that time, because that did not stay like that. So it allowed us to sort of estimate what the reproduction number was, how it changed over time. And so it did drop when the interventions were put in place. It allowed us to estimate just how many cases there really were. And it allowed us to also, because although there had been a lot more cases than had been reported, the population of Wuhan is about 10 million people, and by no means all of them had been infected. In fact, still a very tiny fraction of them had been infected. So this epidemic was declining not because it had reached some sort of herd immunity, but because those public health actions that the Chinese took did work. They did reduce the cases. So even though we were very sceptical about their data, by combining it with all the international data, then we could sort of draw inferences about what really was happening in China. Okay. I said one of the other things that we did was to, all of us were looking at trying to characterize the natural history of the infection, this brand new infection. One of the critical things is trying to look at delays to onset. You can see onset to death, hospitalization to death, these delay distributions, serial interval distribution, and so on. And with that sort of information, you can start to put, again, a simple model together. So you can then, and this is just a sort of cartoon of infection. So if you know those kind of distributions, so if you know the time it takes on average and the distribution between getting infected and you becoming infectious, you becoming infectious to others, and so on, then you could start to simulate drawing from those distributions and look at the potential impact of something like contact tracing. So this is so for instance, this is a cartoon saying, okay, if this person A was infected at this point, they become symptomatic. This is their incubation period, because we know that, from those studies of the incubation, so we can get the incubation period, and then they become, this is their serial interval, because they start to infect this person. They're now infectious, and then they can infect this person, and then perhaps they infect this person, and then perhaps we isolate them at this point, and so they don't infect that person, and so on. So once you get these kind of estimates, then once you have these estimates, then you can start to put that together in a model to simulate the impact of in this instance, isolation. To look at, how effective will contact tracing be, and isolation. And this is essentially looking at lots of different sensitivity analysis to different things, but all along the bottom here is we've got the fraction of our contacts that we've traced, and this is the simulated outbreaks that have been controlled. So you want that to be, it's close to 100%, so you want to be able to control all of your outbreaks, yeah? And in order to do that, and these are things like different reproduction numbers, so that's the lower, if we took a reproduction number of about 1.5, 2.5, 3.5, reality was in this region, somewhere around here. And these are different things like how many initial cases we have in our outbreaks and so on. I won't go through all of this. But you can see that in order to have a reasonably high probability of being able to stop an epidemic through contact tracing and effective isolation, you have to contact trace a very high fraction of your contacts, somewhere in the region of sort of 80% or something like that, to have some sort of certainty that you might start to stop. So we knew fairly early on that contact tracing would have to be really good, and isolation would have to be absolute isolation for it to be effective. We never got anywhere close to any of that in this country. But we knew that pretty early on. Okay, I'm going to skip forward now and look at, and I'm going to probably skip half my talk, but I'm going to talk about the next thing, what we did in March of 2020. Okay, so this is kind of some of the most high profile of the stuff, looking at sketching out what were we trying to do. Again, sketching out, planning scenarios, how big, how nasty might this be, and what's the impact of different non-pharmaceutical interventions, NPIs. Okay. The model I've sort of walked you through, so it's that kind of somewhere in between train set. It has age structure, but actually not much else. So it's quite simple. It's quite a simple model. We have age-dependent mixing. It's this model that I showed you before. It was fitted to data from around the world, so all the data we could possibly collect, looking at to try and estimate whether there was age-dependent susceptibility and age-dependent probabilities of disease, which of course there actually was. I'll skip that, but that was. And then these were the results. So this was the sort of work that we were doing. This is early March of 2020, trying to look at the impact of different interventions. So this is our base case, and these are just sample runs. So each line there is a different simulation. So we're just drawing from these. So there's some variation because we're drawing from the parameter values from different distributions. Okay. So this is the base case. The blue things there are when schools are closed, not because we close the schools, but because school holidays. Okay, so that's just marking school holidays, which does affect contact patterns in children, but also to a lesser extent in adults as well. So these are and along here we've got new cases, then we've got ICU beds required, and so on. And these are different policies like school closure, and the orange shaded areas when we put school closure in place, physical distancing, shielding of older people, self-isolation, combinations of those. The scary stuff is on the right hand side, just the numbers, so total numbers of cases in millions, total deaths measured in hundreds of thousands, so leaving an epidemic run, take no measures, 350,000 deaths over quite a short period of time. Even with all of these interventions, even with these interventions in place, we're still talking about hundreds of thousands of deaths, perhaps 200 to 300,000 of deaths, even with the combinations. This was the really scary stuff. So in terms of peak demand for ICU beds with an unmitigated epidemic, that's about 50 times as many ICU beds as we actually have in the country. So that would have been the demand for ICU beds if we'd have just let this thing run and take no measures. Even with these measures in place, we were overwhelming ICU capacity by orders of magnitude.
Phil, you've got a moment.
Yeah.
Why would the results of the combination look worse than each of the NPIs on their own?
There's a bounce back with the combination. So some of these are. Which one? Combination here, is it?
All those things on the right hand side.
Yeah, it's because there's a bounce back, and it depends how long we measure it for. Yeah. You can't see it very well on these ones, but it bounces. You can see it's controlled here, and then it bounces back. Yeah. Because we assumed that we just do this for a certain period of time. You could see what we were assuming, some months, guided by, guesswork really. How long might we be able to do these sorts of things for? And if we stop it and just let it go, then... and actually, that's the assumption that we had here, was that if we just stopped these interventions, people would just go back to normal life, right? That was absolutely wrong. They did not. We still haven't, 4 years later, gone back to normal life, yeah? In fact, the pandemic has changed normal life forever. So people work at home and so on. So, but that was a fundamental mistake that we made, to say that it would just bounce back, and in fact it didn't. It didn't because people's behaviour. Everybody expected, remember when the pubs were reopened again, they thought they would be packed. They were not. People avoided pubs because they knew they were risky. So, and that's one huge weakness in our models, is that we can't predict our models. We don't have models of the psychology. We can't predict people's behaviour. We were measuring people's behaviour as they were happening, but we are still incapable of being able to predict with any accuracy how people might react to certain settings. Okay, so that was, so they were very eye-watering, horrendous actually. This was definitely sleepless nights. Well, we were working through the night here anyway, but we did come up with one way through. I felt that the debate at the time was very polarised, between either just throw the key away to the economy, just go into a lockdown and forget about it, and just stay there until essentially vaccines come, which would have been, who knows. I mean, I think most people's best guess was about 18 months, but it could have been longer and it could have been never. And so going into a lockdown and waiting for vaccines or some other technological solution seemed like a big gamble, and seemed like a pretty terrible option from an economic point of view. The other option of letting it run was truly horrific, as I just showed you. And even those interventions that kind of put in place for a few months, all of that looked really horrendous, as I just showed you. We thought there may be a way through, where a kind of compromise which took both elements of both of those strategies. So you put in place some level of interventions for some period of time, and then on top of that have an intermittent lockdown when or if cases started to go above your threshold for whatever you could cope with the biggest pinch point, which was ICU. So if the ICU capacity started to be or was close to being breached, then you would go into lockdown and bring cases down. And it depends what your threshold that you would use. But so we came up with that as a potential kind of intermediate strategy. So you would have a long-term, yes, you would have some things in place for over a long period of time, but they wouldn't be that severe. They wouldn't be severe enough to stop the epidemic from growing completely, just slow it. And then on top of that, when necessary, go put an intermittent lockdown in place, lasting a shortish period of time. And we felt that could be effective. So that's what this is describing here. And you can see that we could potentially keep the numbers of cases low. When we did that, it did suggest that you could, of course you could, so this is now looking at ICU capacity, you could keep the NHS working because that's the whole, your trigger was once the ICU capacity starts to get to be, close to being breached, then you would trigger a lockdown to bring the cases down. And so you could keep the NHS working, and you could keep people who needed treatment getting treatment, and it would reduce the numbers of cases and so on and so forth. So this, in terms of the total numbers of deaths, our early projections suggested, and of course there's a lot of uncertainty around these, but our early projections suggested that following a strategy like that, you could keep the numbers of deaths down to, well, just tens of thousands, which is still very, pretty horrific, but a lot better than what we were dealing with earlier, which was hundreds of thousands. So we felt that that was a strategy that actually could work, and in the end, we did actually use this strategy. But we didn't plan to use this strategy, we just used this strategy by accident. So when ICU capacity became stretched, we went into lockdown, and then we eased it, but we kept a background of interventions in place. So this is exactly how we did manage the epidemic, but we stumbled into it rather than planning. We should have planned for it, we could have planned for it. The idea, of course, is to stretch the epidemic out for as long as you possibly can, and in doing so, of course, that buys you time to get a vaccine, and so on. And if you don't get a vaccine, eventually you will get herd immunity, but over a very long period of time.
If we had twice the number of ICU beds,
yeah,
what would the modelling look like?
Yeah, well, so this is looking at different thresholds for ICU. So we did actually increase the number of ICU beds. So this is looking at different thresholds so this is ICU capacity of 1,000, I think, 1,000 bed, 2,000, 5,000. So how many? We actually have about 4,000 ICU beds in the UK, but obviously they're needed for other purposes. So how many of them could you have devoted to COVID patients? So if you've got more capacity, then you could run the epidemic hotter under these sorts of circumstances. In fact, later on, about a month after we did this, we went through in some detail about are there any benefits of running the epidemic hotter? And honestly, there were none. There was no point of running the epidemic hotter. This is about a third of the way through my talk, but I'm going to stop there and move right to the end. So I'm going to just skip through. I just wanted, maybe I'll just show you just quickly. So that modelling work that we did then, that was done. We didn't have much data in the UK then. That was done in early March, and of course there were virtually no cases in the UK in early March, and so it's very difficult. So we could look at all the data from elsewhere, construct a model, run that model, but we couldn't ever. But at that point, we couldn't tie that model to data from the UK. Later on in the epidemic, we had absolutely unbelievable data from the ONS survey, from the massive amount of testing that was happening, and so on and so forth. So we had fantastic surveillance data later on in the epidemic. And so later on in the epidemic, what we could do is fit our model to all those surveillance data. And this is, you can't see that very well, but these are NHS regions here. So this is East of England, London, Midlands, and so on. And each of these are a different data stream that we can fit the model to. Yeah? So this is deaths, admissions, hospital beds that are occupied, ICU beds occupied, PCR positivity from the ONS survey, or I think actually this might be from REACT. I think this is from REACT. Seropositivity, so looking at serological data that we had, and this is actually a model result on attack rate. So I don't know if you can see, but the model is fitting to all of these data simultaneously, and by doing that, by fitting to all of those data sources simultaneously, it constrains the model. So our model is then calibrated, is better calibrated to the epidemic, what's really happening in the UK, constrains the model, and our projections are likely to be a bit more accurate. And if I skip forward, and these are data on behavioural data that we were using. So this was data. This was in autumn of 2020. We were looking at potential lockdown scenarios and so on in the autumn of 2020. And these are data in, do you remember the tier system? Liverpool was famously in tier 3 and Manchester fought to stay in tier 2. Well, these are data on mobility collected by Google. These are actually from people's mobile phones and where people are moving around. Are they in a workplace or in a shopping centre or whatever it might be? And from those data, then we can kind of infer we can see how mobility was being affected according to what tier you were under. And you can see actually this is tier 1 on the left, tier 2 and tier 3. And there wasn't a huge amount of difference between tier 1 and tier 2, and there wasn't a massive amount of difference tier 3, but tier 3 did reduce mobility. From that, we could estimate the impact that tier 3 was having fairly, and you could see tier 1 and tier 2 really having very little impact whatsoever. And we could put all of that together to look at a model, and we could compare our model with what actually happened. So these are our projections. This is done in through a period between September and end of October, I think. These are the dates of all of those projections. So the first projection is shown in purple. So it was done at the end of September. Okay, the data is shown in the black line. Yeah, but at that point, none of this data had been seen by us. Yeah, we hadn't seen that data yet. It hadn't happened. Okay. We'd seen these data, and I showed you all the other data we were using to fit the model to, and then we were projecting forward. Okay, so that's our projection. This is for admissions, these are deaths, these are hospital beds occupied and ICU beds occupied. So again, this projection, this is looking at ICU beds occupied, what we're projecting at that point. You can see our uncertainty getting wider. So this is at the beginning, this purple one, yeah, and the later ones are shown in these different colours. So the next week we went through the whole process again, and you could see this is the next week on the 5th of October, and these are our projections here. And then and you can see actually that was our projection for the week before, and we got it pretty good, yeah. So you can see that what we were projecting actually we were pretty accurate in our projections as we were going forward. We didn't get it all the way, but and this is deaths. That's only because of the delays in deaths. Because this is done live, so we were doing this at around the beginning of November, and of course because there's a delay in death reporting, they don't come through. So it looks like the deaths. Epidemics in real time always look like they're turning over and coming down. They're not. Don't be fooled. Yeah, it's just the data's delayed. Okay, and you can see that happening there with that death. With those deaths, because that's the biggest delay in the data set. But you can see, so this is an example of us trying to validate our own model by checking our projections against them, what then subsequently happened. And you can see it was pretty good, actually. And that was the stuff we were doing, and all the other groups were doing exactly the same, and we were also checking all of our projections against each other and seeing what happened. Okay, so actually, and then we looked at the impact of different interventions. Wales had done a circuit breaker just before half term. Northern Ireland had done something similar. They had different sorts of interventions. They were slightly different. We could look at the effect of a Wales-like circuit breaker, a Northern Ireland-like circuit breaker, without school closure and so on. And that's what we were looking at here. Strength of the intervention, the duration of the intervention and the timing, looking at these, what to do with the autumn wave and so on. So the government were unbelievably well informed, or they would have been if they looked at any of this, but they didn't. Instead, what they did was they looked at some early, reasonable worst case. These were not projections of what we thought would happen, but the reasonable worst case, and which we'd done at the beginning of October. And each of the main groups that were doing it, which was PHE, ourselves, Imperial and Warwick, had been asked to do some reasonable worst case. The worst you can imagine might happen over the next few months. And the idea was that at some point the Cabinet Office would bring these together into some, or SPI-M and Cabinet Office would bring these together into some sort of consensus reasonable worst case that they could plan to. Somehow that got out into government and was used by government to justify the second lockdown. When they had not just our work, but all of the work by all the other groups as well, and the consensus estimates, all doing something like this, and the consensus estimate, and comparing how well we're doing. They ignored all of that and just used these reasonable worst case scenarios from the beginning of October. And of course then we got punished in the press from it. You know, this is from the Daily Mail. Apocalyptic forecast, 4,000 krona. And what, of course, the Daily Mail did, instead of looking at the consensus, which is how we would have done it, they just took the worst case from the worst case scenario, and they accused us of being alarmist. We weren't being alarmist; they were being alarmist by taking the worst case of the worst case scenario, and instead of using the considered estimates that we were actually providing with the government and had done all the way through the autumn wave. So just one quick use of the abuse of modelling and so on. I'm going to skip this, unfortunately. This was another simple model that I'm going to skip. So these are some of just the last couple of slides, just some of my lessons learned. First of all, models are essential in this field. First of all, one, just to interpret the data, to see to get a better understanding of what's going on. I sort of showed you a bit of an example with Adam's work, trying to interpret what's going on in Wuhan. By using multiple data sources, you can maybe account for the biases in those and come up with a better view of what the epidemic's what's really happening. Second thing, for the scenarios and what might happen if you don't use a model, then an explicit mathematical model, stuff that I've been talking to you this evening about, then you're going to use a model in some expert's head. Yeah? So it's still a model. How many cases might there be if we introduce this, if we do a lockdown, if we don't do a lockdown, how many cases might... Someone is going to give you, so either an expert like Callum or myself, or actually even worse, just some policy maker. It's in their head. They're still using a model. It's not written down. It can't be challenged. It's just implicit and in their head. So I honestly think with all its foibles and difficulties and so on, it's much better to be explicit, write it down, show your assumptions, show your working, people can challenge it. It's very difficult to challenge a model in someone's head. So it's certainly better, I think, than the alternative. Results are much more reliable if the model can be calibrated. I showed us doing that later in the epidemic and how we got better at it. The models are pretty simple, and one of the big problems with them is we can't actually predict people's behaviour. In fact, one of the biggest things that was difficult to predict was the government's behaviour. So that was actually because they're the ones intervening and causing you to all change your behaviour. And so it's very difficult to make any projections going forward when you don't understand how it might be they might react to them. There was a bit of a tendency to over-rely on models, I feel. So, for instance, there were almost no trials of non-pharmaceutical interventions, but they could have been done. So the models can tell you what the effect of those NPIs, non-pharmaceutical interventions, might be. And also, once you put those things in place, you can use models and epidemiology to try and infer what might have happened, what might have been the effect. But it's really difficult. And in many instances, we could have done cluster randomized trials to determine whether this NPI was effective or not and how effective it was. And we didn't. And I think that there was a huge wasted opportunity. You think of the level of evidence that we require for pharmaceutical interventions, and yet for these non-pharmaceutical interventions, which had a huge impact on people's lives and livelihoods, we didn't subject them to anything near the same level of rigour that we do for drugs. Why not? They cause just as much damage. These non-pharmaceutical interventions also cause damage. There's just as much of a problem of equipoise about should we introduce this or not, and yet they were not subject to the same levels of standards of evidence, and I think that's wrong. So we, I think, over-relied on models because we can do that nice and easily and cheaply, rather than going out and doing the difficult studies. We should have done them. There was repeated, and I think potentially deliberate, misinterpretation of scenarios and forecasts. So I showed you that Daily Mail example there, where they're saying that this stuff was forecast. Actually, it's even funnier. If I go back, on this slide, which is the one, it says here, early SPI-M working analysis, right? These curves represent scenarios from a number of academic modelling groups. These are scenarios, not predictions or forecasts. Apocalyptic forecasts, they don't care. So there was a deliberate misunderstanding of what a forecast is, like it's going to rain tomorrow with an 80% chance or not, and you can't do anything about it, compared with a scenario. Yes, we can reduce our carbon emissions and so change things in the future. There was a complete misunderstanding of that, and I think because it was so repeatedly done, I think it's hard to believe that it wasn't deliberate. There was a complete lack of economic projections. So these, on the other side of it, so we have these health impacts that we were slaving away, working on throughout. But these things also had an economic impact, huge economic impact. Where were they? Where were they in the... Did you see any of those? No, I didn't see any of them. If they happened, they didn't come out into the public domain. So the debate was stifled. And in fact, if they happened, they might not have done. And I think in many instances, it was just expert opinion or even just policymakers' opinion about what the impact of such a policy would be. There's nothing to show, no actual projections looking at the economic impact. If you could find them for me, then I'd love to see them. You can't. So I think that was a huge failure on the side of economics and so on. Just wider kind of lessons learned. First of all, UK science had an absolutely enormous impact on not just in the UK but across the world. We really did lead in terms of surveillance, genomics, clinical trials and so on, and I think also in modelling. It showed what could be done given the resources and the will. And unfortunately, I was chatting with Ian almost as soon as the epidemic finished and the resources dried up, the will dried up. And so when we got hit by another epidemic almost immediately afterwards, and access to data dried up. So in terms of monkeypox, which could have been very bad, I mean, in May of 2022, we didn't know how bad that might have been. Access to data had, and all of that sort of infrastructure. We went back to the bad old days of, submit an application and we'll send it through our, institutional review board, and we'll tell you in a year's time whether you're successful. So I think that we took a huge step backwards, and I really think that we should go back to. We have the capability in this country to do really high quality data science, and we ought to utilise that capability, and unfortunately we're not. I think SAGE did actually work really well at synthesising the scientific evidence. I do think that our policy making was not cautious enough, particularly at particular stages of the epidemic at the beginning. And admittedly, we didn't really know that well what we were dealing with, although frankly by the middle of February we did. And we were certainly not cautious enough in the autumn when we really let the thing get out of hand. And I think one of the things that lessons that really need to be learned is that because you have an exponential increase in cases in epidemics, and your data is always delayed and lagged, it's much worse than you think it is. Much worse than you think it is. And so what you have to do is you have to react much harder, faster, and Patrick made this point time and again, and wider than you think you do, than you think you need to, because of those sorts of exponential increase and delays in data.
Why is there such gatekeeping on all on that data?
I don't really know. It's just, I think a lot of it's to do with nervousness about whether you can share data, whether they own the data, and so on. But it's a huge drag.
But presumably an institution like
yeah, and so we just had access to almost all of the data at an individual level. All of us SPI-M groups did. And then as soon as the COVID epidemic finished, that access then was lost, and the monkeypox epidemic started literally 2 months later, no access to it. So, and that's just one example, but it's many like that.
So in relation to data, of course, the government changed the law.
They did, yeah.
So once that lapsed,
yeah, it went back to. Yeah.
The difficulty is when you ask people whether they want their data sharing, the answer is no.
Yeah.
So how do you overcome that aspect?
You persuade them by saying, well, look what we can do. If you don't have to do anything at all, and I think you can easily persuade people about the value of it.
Okay, so they're happy to share data if they think it's going to something like this.
Yeah.
They're not happy to share data if they think it's going to the pharmaceutical industry.
Correct.
Or to others.
Yeah.
And of course they don't trust the government in this case.
I think they do trust. I think the levels of trust for academics and the public health organisation. Public health is doctors, academics. Public health is high. I agree that there's. If you say Richie Sunak wants your data on, then that's not going to go down very well. Or if you say GSK wants your data on, then people will say, well, I'll sell it to them. Yeah. But I do think that that we've made this way more difficult than it is, and the pandemic showed exactly that people were happy to share the data, and look what we managed to achieve in Callum was with COSIN and so on. It was phenomenal, and I think there needs to be a shift. We need to go back. I think that it's unethical not to share, not to allow access to these sorts of data. I mean, there are people dying because we haven't done the analysis of this combination of drugs against that condition, just because nobody can be bothered to go through the whole rigmarole of trying to get access to that. That seems wrong to me. So we could save people's lives now at almost no cost just by doing some data analysis, and we don't, because it's unethical, or it's not unethical, but we put so many barriers in place that people give up. The government needed a clear strategic direction. They didn't have that. They flip-flopped between lockdowns and eat out to help out and so on. And that cost us a lot of lives and cost our economy as well. There are trade-offs. There are trade-offs between health and wealth. And there are also trade-offs between acting at the individual level and acting at the national level. So the idea of test and trace was essentially to restrict the activities of the most high-risk individuals, lock them down, so we all didn't have to be locked down. That never worked because we didn't effectively get to them. We didn't effectively lock them down or pay them to be locked down or anything like that. And instead we locked everybody down. And I think there needs to be much more of a debate about that. You look at what they did in the Far East, where actually those measures did work, but they were brutal on. If you were a case in Vietnam, obviously you were isolated, not at home like we did. You were isolated in a hospital, in an isolation ward in a hospital. Your contacts, all contacts for the previous 2 weeks, all of those were isolated for initially 2 weeks, and then actually in the alpha wave 3 weeks, plus tested on going into isolation. So they were taken out, essentially put in army barracks. All of the contacts going back. So for each case, it would have been dozens and dozens of people, and they were isolated in alpha. So they were not allowed to stay at home either. And the contacts of the contacts were told to stay at home for 2 weeks and tested when they came out of isolation. We didn't even do that for our cases. We didn't even test the cases to let them out of isolation and so on. So the difference in how we implemented that same strategy it's like night and day. Now, I'm not sure people here, or I'm not sure we necessarily agreed with the Vietnamese Far Eastern strategy, but we needed a debate about it. We never had that. So there are these sort of debates about that, about civil liberties and how we should design our strategies, debates about how we do trade off health and wealth. What's the value of a life? Is it acceptable that 100,000 people die? In fact, we ended up with 200,000. Is that acceptable or not? And so on. So none of that happened, and I think that was a huge wasted opportunity for us to have those debates. I strongly think that scientific advice should be open to scrutiny. Initially, SAGE made a mistake on that, and they changed it, and it was much better since it was open. And again, I throw out the economic advice. What was it? Did it stand up to scrutiny? Would it stand up to scrutiny if you ever got to see it? I suspect not. Otherwise, it might have been out there in the public domain. And we desperately need more numerate decision makers and policy makers. It is really shameful, and I think that many of these, it's awful to think that people died as a consequence of that, but I'm pretty sure people died as a consequence of not understanding exponential growth and the need to act fast and so on. And I'll finish up with just 2 quotes that are some of my favourite ones. So this is George Box on the left, yeah. It's a very famous quote, all models are wrong, but some are useful, and that's pretty much sums up the field. Yeah, they are all wrong. Remember, there's the train set analogy. They're not trains, they're not a whole integrated transport system, they're simple, they're simple models of the very complex systems, but they can still be useful. And on the right, from Austin Bradford here, which I think sums up really where we should have been. All scientific work is incomplete, whether it be observational or experimental. All scientific work is liable to be upset or modified by advancing knowledge. It's the whole point of science. That does not confer upon us a freedom to ignore the knowledge we already have, or to postpone the action that it appears to demand at a given time. That we fail to do on many occasions, unfortunately. And I'll finish there.
Normally we have questions now, but questions have been asked quite a lot through the process. I would still like to do some more questions though. Professor Ian Buchan, you have to speak up, sir.
Thanks, John, for a great talk. Regarding the let it run early arguments, given that most of those arguments are made about hospital admissions and capacity and deaths, should we think about more further term outcomes? For example, this COVID CNS study that Michael Greta was here, looking at the effect of COVID-19 pre-vaccination, taking acute convalescent serum from sample people, but also from those admitted to hospital with influenza at the time, showing that immune dysregulation led to an inflammation effect likely in peripheral markers of inflammation in the brain. Long-term studies of that, about 20 years of brain aging. If you think about that in economic terms in human capital,
Massive,
and you start to project that and run various scenarios around that, it's a big argument for not letting it run, but it's looking much further ahead at the human capital and the effect on your economy and society. Should that be taken into the next debate?
Definitely. At the beginning, of course, we didn't know those consequences. I mean, you could guess that something nasty might happen, but you couldn't ever quantify any of those things right back in March of 2020. We didn't know about those sorts of things. We didn't know about, that whole gamut of long COVID, and there's a whole range of, well, you're a clinician, not me, but a whole range of sort of clotting disorders that are associated with COVID infections and so on. So we didn't know about that stuff then. So we couldn't really, I don't think, anticipated it to be able to put it into the analysis then. You didn't need to do that. I think you do need to do it now to make a case for still controlling COVID, of course, because it's still there, causing it's about 4% of our hospital beds are still filled at the moment with COVID cases. That's 4% of hospital beds we can't use for other things because we've got COVID cases in them. That we didn't have. So our hospital capacity needs to be about 4% bigger than it was before the pandemic, just to cope with just to put us back in the pretty crappy position we were in before the pandemic. So there's lots of things that there's still an argument to be made for better control of COVID. That's why I still think we should still do controlled trials of things like testing strategies in care homes, wearing masks in care homes, and those sorts of things, looking in hospitals to prevent hospital transmission. There's plenty more that we could and we should still do, and I think that we could and should still do many of those in use trial design, but also observational data. I wouldn't want to ignore that, but I think there are plenty of trials that we could still do, and we should still do them, because COVID is still an issue, and there are still things that we probably are still learning as long-term consequences that will still come up.
Influenza is still having some brain aging that's only just surfaced by the
Well, exactly. So, there's more to do.
I'm looking to try and make sure I don't miss out any questions. Please.
My husband's Andrew Swift, he's the ENT president, and we badly got COVID in the 2nd of March of the first lockdown. And my husband was phoned twice a day by NHS England, and he told them very clearly that we had no taste and smell. And he carried on with ENT, telling the government, telling NHS that this was a problem. And they kept saying, no, it's just, nothing. And yet my husband was telling them, all over Europe and all over the world, he was contacting them, and they were saying, it is a huge problem, and you must get the government to listen to you. We had many friends, colleagues, who lost their sense of taste and smell completely, unlike actually this was one of the main problems. Now, if we actually had said, when the NTUK clearly stated and told them this in March, there were so many people running around who had the infection, and the government, NHS, just wouldn't listen. And that was a huge problem.
Yeah, I mean, this is the issue of case definitions, and it sounds really technical, dry and boring, but it's very, very, very important. So, whether you allow loss of taste and smell to be part of your case definition or not makes a big difference in terms of sensitivity and specificity. In fact, that story with China, and the reason why they had 41 cases, and they only had 41 cases until towards the end of January, is actually just a case definition issue, unbelievably. Because, just to go back, just to show how important these can be, because part of their case definition in Wuhan at the time was, and we didn't know this until much later, although we started to guess it might be this. So part of their case definition was you had to have been to that wet market. So you wouldn't be defined as a case, you wouldn't be tested or defined as a case if you hadn't been to that wet market. Remember, it was a wet market that was implicated. So that was the case definition, you had to have been to the wet market. So cases that had not been to the wet market were not counted. And so the reason, and they closed the wet market, and so the reason why the number of cases stayed at 41 for most of January was because they were the 41 that had been infected, so had contact with the wet market. And we can laugh at the Chinese, but we did the same thing effectively. So at the beginning, in February and early March of 2020, really the only people we tested were people who had come from overseas. So we were testing people from high-risk areas, which was China, a few other Far Eastern countries, and they were the only. So if they came and they had a cough, they would be tested, but everybody else wasn't tested. And so you weren't tested, or your husband wasn't tested.
Yeah, we were tested.
You were tested, okay.
On the 2nd of March.
Okay, but it was unusual. But your physician said, yeah.
No, I'm not one.
But your husband did. So, but it was very unusual for someone to be tested if they. So you had to have been in contact with a known case, or essentially have come from a high-risk area. When the high-risk areas was actually Italy and France. That's actually where we imported our cases from, but they weren't included in our case definition of high risk. And so we were only testing about 4% of our cases, in February and March. So we did the same thing. We had this case definition, which part of it was a geographical case definition, geographical component to the case definition, which meant that we really didn't test any, or we tested very few cases. And so it looked like we didn't have a large number of cases, just like the Chinese looked like they didn't have a large number of cases in January. But it wasn't true. It's just that we weren't looking for it because of our case definition. So it was very difficult to move the government to take probably the most extreme measures they've ever had to take, not being in a war, based on just a few cases. Because we literally had tens of cases in March. We didn't. When we went into lockdown, we actually had about 100,000 infections every single day. That's how many people were getting infected by 23rd of March 2020. Over 100,000 people getting infected every day. But we were reporting hundreds.
I remember when they first released international data, that most countries, the cases were all around the country. There weren't loads of cases, but they weren't all in one place. There were dozens around the country. And I just looked at that, but we're clearly witnessing in the community to have cases all around the country. It must how could the government not just think, well, there must be more cases?
I mean, I think people did know that there must be more cases. But it was a challenge to actually estimate how much more, right? And that was one of the critical things that we did Well, I know the dates we did it. We did it on the 11th of March, actually the same date that we did the other stuff. 10th and 11th of March. And then other people looked in the following few days. So I think we were the first to try and estimate how many cases were being missed. We had a kind of rule of thumb that we were using before then, based on deaths and sort of scaling up from the deaths. But the first kind of real formal estimates that we did, trying to work out, and that's why if you look through all the sort of stage minutes and things, on the 13th of March, all of a sudden it's like we're much further along. And that was partly because we'd estimated how much work, we were massively uncertain at that point, but we had tried to estimate how much more cases there actually genuinely were. And the second thing was, it was starting to become obvious. You could see ICUs were starting to fill up, so it was starting to become really, really obvious. And so it became obvious on the 13th of March that we were way further along the epidemic than we thought we were.
Yeah, if I could chip in, we did the first Cosin report, which wasn't seen by Sage, it was seen by Jonathan Van Tam on the 10th of March, and I remember because it spoilt my birthday. And I think we had 891 admissions in every part of the UK and every hospital in the UK, which was not consistent with what was being reported.
I can tell you, I think on the, I mean, you could look it up, but I think on the 13th of March, we were reporting something like 60 cases a day. I mean, it's just complete nonsense.
And we had close to 1,000 in hospital.
Yeah.
And that data, people.
I think it was 65 cases. I think actually, I think it was 65 cases were reported on the 13th of March. I mean, we were having tens of thousands of cases at that point.
How would you do things differently? Hopefully you never have to, but take it away from the government?
No. I mean, look, we were not unfortunate because we make our own luck in this, but we did have a really very poor government. I don't want to make political points, but they were very. Boris Johnson couldn't make a decision, basically, and you have to make a decision. Just thinking it will go away if you don't make a decision just will make it much, much worse. And that's the problem, is that these things grow so fast that, at the beginning in March, the epidemic was doubling about every 3 to 4 days. So in a week, it would double and then double again. And so if you delay things by a week, which we did, I mean, I think we could have gone into lockdown on the 13th, around the 16th of March, and we went in on the 23rd of March a week later. Probably 25,000 people died as a consequence of that. So taking the same decision, but taking it 1 week later, killed 25,000 people. In the autumn, I mean, okay, in March, things were much more uncertain. It was a new disease and stuff. There's no excuses in the autumn, and we waited. Okay, it wasn't growing at the same rate. It was doubling about every week or two in the autumn because there were still measures in place, and people were very, very careful actually. But still, instead of taking measures in the early autumn, let it go until November before actually doing what had to be done. And it did have to be done, and it would have been same measure. You put the same measure in place but done it in September as opposed to November, it would have had a much bigger effect, and people wouldn't have died as a consequence of just delaying it. So, and it would have cost the same. It's the same measure. So that's why I think someone asked me about letting things go high, and the cost of an intervention was exactly the same, whether you did it early or late. If you do it late, then you've got lots of cases. If you do it early, it's the same intervention, it costs the same, but you don't have any cases. You have much fewer cases. So the costs were the same, but the benefits were innumerably higher. So the delay, unfortunately, cost an awful lot of lives unnecessarily.
Paul's question from Paul.
What are your feelings about the steps that government bodies like the UK Health Security Authority have taken since then to try to better prevent?
Yeah, I mean, I think that they've taken. I do think they've done a pretty good job. I think one of the big issues is that old adage of generals always fight the last war, and we fought flu at the beginning. So with flu, there's no way you would try and contact trace your way out of flu. There's really not all, testing. You've got just, yeah. So and so you would let it run with flu. I mean, you would do some measures, take some measures to slow it and stuff like that. But you're not going to try and stop it dead in its tracks, almost certainly, because you'd have to take such extreme measures. And the really important thing is we've got antivirals. We've also got antibiotics, and a lot of the consequences of flu come from a bacterial superinfection. So we actually have pharmaceutical measures. We also, would have vaccines in place. Potentially, you could have pre-pandemic vaccines and so on. So we have stuff to use for flu, and we basically use the same playbook, but without all of those drugs, without all of the. So we absolutely made a mistake fighting the last war, and so I'm really keen that we don't make that mistake again, because the next pandemic will be different. The next pandemic might affect children. It could be something like, I'm scared of enteroviruses. There's a lot of them around. They affect children. They cause neurological consequences in children. What about that? That would be very different to COVID, which affected the elderly. Yeah? How would we cope with that? It's something where actually mostly it's fairly mild, and every now and then you have some child with neurological consequences or muscular problems or something like that. How do we do? How are we going to do that? Because frankly, one thing we probably should think very carefully about is closing schools. Nobody wants to close schools now because we closed them in COVID.
So I'm going to get one question. So one thing that came out relatively late with the human challenge study, but came out of some other observations, was that coronavirus 2 is in fact, a lot of people are infectious a day to 2 days before they develop symptoms. And I'm not sure that was well reflected in our policy or our models. Or is that my misunderstanding?
It's definitely, no, I think that's a misunderstanding. It was definitely reflected in every single model. We knew that right from the beginning. That was known from January. So you could see, so that was known, absolutely known and included in every model. So the stuff we were looking at, for instance, I showed you that simulation of trying to look at the effect of contact tracing. Part of the reason why you have such a high fraction of contacts is because you can be infectious before you show symptoms. So that was absolutely known by January. Politicians pretend that they didn't know this, but maybe, I don't know. I've never understood that because all of us knew it and included it in all our models.
Thank you. Well, look, can you just, I'm going to stop the questions. Can you just come down here in front of us all? Thor might get out his mobile phone. You need to stand down about there. There's one further bit of ceremony left. So one of the honours is that people that actually make the effort to come and give a lecture here get a medal. And so it's my great honour to shake your hand and give you the President's Medal. And